Welcome to today's installment of the seminar series, the webinar series on macroeconomic modeling and pandemics. It's been a fascinating tour, part of force tour across a range of approaches. We're delighted today to have Dirk Krueger to present a paper. I'll say a word about you in a second. Also, as I've said before, but there may be maybe some newcomers, this is a joint initiative, Frankfurt, Stanford, the Macro Model Comparison and Macro Modeling Initiative. We've done a whole range of projects, including making models available online. I have the hope that not far in the future, we can also make a whole range of macro pandemic models available. Certainly, a number of researchers have also been very forthcoming with putting up their code. Anyway, that's looking forward. Today, it's great to have Dirk here. His paper will be on health versus wealth, on the distributional effects of controlling a pandemic. We had one other paper talking about distributional issues just recently with Gernot Müller. This will be a different perspective. I'm looking forward to it. And also, I mean, Dirk, also is a big part of this Stanford and Frankfurt connection. Although he sits now stuck in Philadelphia, we don't know how he ended up there, but he spent time both in Stanford and in Frankfurt. John, do you want to say something? Greeting from Stanford.
I just want to say welcome. This is a great series, and it's great that Dirk can be on it, describe his work with his colleagues. So welcome, Dirk.
So right over to you, Dirk. It's your floor.
All right. Thank you very much. It's great to be with you. It's great to be back in Stanford and in Frankfurt at the same time. So Corona makes that happen. This is joint work with Henry Glover, Jonathan Heathcote, and Victor Rios-Rull, and it's health versus wealth on the distributional effects of controlling a pandemic. And so in terms of the motivation, from our perspective, the recent Corona crisis has basically two dimensions. It has a health dimensions with massive number of deaths around the world, initially exponential growth in the daily deaths, say, for example, in the US. And one thing that's important for us, because when we think about the distributional aspects, we think about two dimensions. First dimension is between the young and the old. The second dimension is between workers and sectors that could continue to work through the Corona crisis, and then workers and sectors that could not work. So one important observation is that there's a very strong age dependency of the death caused by Corona, mainly affecting the old individuals. On the wealth side, so when I say wealth, I really mean the real side of the economy. And if you look at the data, you have record new unemployment claims, you have a spike in the unemployment rate, massive GDP decline. So what this paper is basically about is to ask, what are the distributional consequences of the epidemic itself, and what are optimal mitigation mechanisms when the government comes in and tries to shutter down parts of the economy to control the pandemic. Just to sort of motivate the analysis a little bit on the health side, what I have here on the top panel is the number of daily deaths in the United States. So that started sometimes in mid-March. Then you had exponential growth in the number of deaths. It stabilized around 2000. And recently that has declined somewhat to about 1,500, 1,200 daily deaths in the United States. This decline is partially due to the fact that the government reacted and shut down part of the economy. Of course, the economic costs of these mitigation mechanisms are fairly substantial. The growth rate of real GDP in the first quarter was negative 4.5%. And we don't know what it is going to be in the second quarter, but if you trust the survey of professional forecasters, it's going to be anywhere between 20 and 30%. So that is quite massive. If you actually look at the health dimensions and who is dying here. So this is a figure that comes from New York City, and it breaks down the number of deaths by age. And what is this meant to show is, if you look at the share of total death by age, basically, if you are young, and by young, That means for the purpose of the table, below the age of 45, you're very unlikely to die from coronavirus. And the older you get, the more likely it is that you're going to die. So any type of economic policy that slows down the virus, that reduces economic activity in order to prevent death, will primarily be there in order to prevent the death of old households. So when it comes to the health side, the main benefits of mitigation policies will be towards all the elderly households that are less likely to die. On the other hand, if you look at the economic cost of that, here's the unemployment rate. On Friday, we will get a new installment of these observations. The unemployment rate at the end of April stood at about 15%, probably gonna go up quite a bit on Friday for May, to the extent that young households are the households that actively participate in the labor market. They will bear the brunt of the economic costs from mitigation efforts, whereas old households, retired households are only indirectly affected by it. I should say that the unemployment rate paints a somewhat incomplete picture of how bad it looks on the labor market, because the high unemployment rate comes at the backdrop of the lowest labor force participation that the US had for a long period of time. So it's not only that people are unemployed, but a bunch of people are deciding not to even look for work. So these two observations, the fact that who is dying are mainly the old and who is working, mainly the young, suggests that if you now think about economic policy to control a pandemic by reducing economic activity, the benefits will be accruing mainly to the old, and the costs will be accruing mainly to the young part of the population. So what this paper broadly asks, how should we respond to a pandemic like this? And the specific question, how extensive should a government respond to it by shutting down parts of the economy? When should it shut down parts of the economy? What should that share of the economy that's being shut down be? And when should it end? Meaning, when should we come out of the shutdown that we have enacted sometimes in March? And the key point that we want to stress here is that there's very large distributional implications of these shutdown policies, where the health benefits are mainly concentrated among the old, because they are more prone to die from the disease, whereas the economic costs are concentrated mainly among the young that work, and within the young, among those workers that work in sectors that have been shut down, restaurants workers, entertainment workers, relative to workers that work in essential businesses that have not been shut down, or might even have expanded. If you work for Amazon, probably the Corona crisis was good for your labor income and your outlook on economic life. So the argument that we want to make is that if you want to control the pandemic somewhat and want to shut down parts of the economy to slow down the pandemic, there's going to be large distributional consequences. That suggests that not only do you have to think about mitigation policies, shutdown policies, but you also have to think about redistribution policies, because you have to deal with these newly unemployed people that have lost their jobs, not because the economy has turned bad per se, but because the economy has been partially shut down as an active policy response. So our paper is really on the intersection between what are optimal shutdown policy and what are optimal redistributive policies to deal with the loss in income of those individuals that have been shut down for health reasons. So what we do, which in a way is fairly standard in this very new, rapidly expanding literature. So we read Andy Atkinson's paper that has explained to economists how epidemiology works. And we combine a standard epidemiology SIR model, which I will explain in a bit, with a fairly standard macro model with heterogeneous agents. We assume that there can be public transfers across employed and unemployed workers, but that these transfers are costly because you have to raise distortionary taxes, for example. And then in this environment, we assess the optimal combination of shutdown policies, when you should shut down part of the economy, what share of the economy should you shut down, in combination with redistribution policies, What should you do in terms of the income of those households that have been shut down? How large should unemployment benefits be? How extensive should be redistribution towards those households that currently cannot work? So we characterize optimal policy, and as I said, the key interaction is that if you shut down parts of the economy, that creates the need for redistribution because a part of the economy lost their income. But if, on the other hand, redistribution is costly because you have to raise distortionary taxes, then that might reduce the taste of the government policymakers to engage in large mitigation because you lose economic activity through redistribution. And the key thing that we need for this is a heterogeneous agent model. We need people that are young and old. We need people that work in some sectors that are not affected, and we need people working in sectors that are affected by this crisis. So we will have a very simple, in a way, macro model that is just rich enough in terms of its redistributional aspects to be able to talk about that. So if you want, the model in a nutshell is going to be, there's going to be a model that describes the health dynamics in society, and that's a variant of the SIR model, and then a simple economic model that has just enough heterogeneity, young and old, workers in essential and non-essential sectors, to be able to speak about the distributional consequences of both shutdown policies and redistribution policies, and we will analyze the optimal combination of both of these policies. So now let me show you how this, roughly speaking, works. So we will start on the health side with a basic epidemiological model, the SIR model. S stands for susceptible. So there's a group of the population that is susceptible. These are people that have not had the virus. They are susceptible to receiving it. They are not immune yet. Then there's a bunch of people that are currently infected by the virus and therefore can spread it to other people. And then there's recovered people, people that have had the virus. We will assume that if you have had the virus, you are then immune from it. And for all practical purposes, for the evolution of the virus, it doesn't really matter whether you're recovered from the virus and therefore immune and cannot spread it, or whether you have died from the virus and therefore are immune and cannot spread the virus. The one thing that we do on top of the simple SIR model is we think that the group of infected people, just lumping everybody that's infected into one group, that's not good enough for our purposes. So our innovation on the epidemiological side is to introduce a safer SIR model, where safer stands for the fact that we take these infected people and we break them up into three groups. People that are infected but asymptomatic, so these people that have the disease, but they don't have any symptoms from the disease. They continue to go to work. They might not even know that they have the disease, and therefore they happily spread the disease to their co-workers or when they go shopping. Then there's people that have the disease and they're sick. They have flu-like symptoms, which means they know they have the disease. And we will make the stark assumption that if you know you have the disease, you're socially responsible and you don't go to work and you don't go to shop. And then there's people that have the disease and they are severely sick. They need emergency care. They are in the hospital, and therefore they spread the disease to the hospital workers. And the reason we distinguish between these three groups is the way that these three groups spread the disease is very different. The asymptomatic, they spread the disease at work, while going shopping, and also while interacting with people at home. The people that have flu-like symptoms, the assumption is that they don't go to work, they don't go shopping, but they still interact with people at home. And the people that are in the emergency room, they are not at home, they're not at work, but they spread the disease to healthcare workers that take care of them. So the reason we distinguish between these three groups is that the infection probabilities, the infection channels in these three groups among the infected is very different. The probabilities are very different. So we think we have to distinguish between the three. So really, loosely speaking, it's a simple SIR model where just the infected are broken up in three different groups. And these three different groups among the infected, they just have different ways in which they spread the disease. So that's the health part of the model. And in terms of the economics part, as I said, it's a very broad stroke type of heterogeneous agent model.
Can I just quickly interrupt for a second? I forgot to say at the beginning that we will have questions after about a presentation of 30, 40 minutes. So I saw somebody started putting in questions, I think Robert King. That's great. So put in your questions in the Q&A section and we'll come to it when after about 30, 40 minutes. So sorry for the interruption, but I just wanted to encourage people to pose their questions.
And the slides will be available on your website as well. I already sent it in case you're interested in that, as well as the paper. So on the economic side, this is going to be a very stark representation of heterogeneity in the population. There's going to be young and old people. The main distinction between young and old people is that young people work, and therefore young people are more prone to receiving the virus. Old people do not work, and therefore are initially less likely to be infected by the virus, but conditional on being affected, they are much more likely have bad outcomes from the virus, because once they receive the virus, they are more likely to get flu-like symptoms, and conditional on flu-like symptoms, they are more likely to become emergency care-like sick, and conditional on having to go to the emergency room, they are more likely to die. So this is the main source of heterogeneity between the young and the old. The young work, they are more likely to be infected, but conditional on being infected, their outcomes from the disease are much, much better. The second main source of heterogeneity is among the young. You are assigned to a particular sector of the economy. We make the stark assumption that if you're a restaurant worker, you work in a restaurant, you cannot switch over. Those that have seen my paper with Harald Uhlig there, we make the exact opposite assumption and assume that shifting sectors is very easy. Here, that's not possible at all. We distinguish between two sectors. There's a basic sector, which we think of as healthcare, food production, law enforcement, and the government. This is a sector that the government never entertains to shut down. This is so essential that economic activity in those sectors will go on unmitigated. So workers that work in these sectors, they never have any unemployment risk, because this sector will never be shut down through government policy. But on the other hand, since that sector will never shut down, and there's going to be a bunch of infected people working in those sectors, the workers in the sector are more likely to be infected by the disease. And it's also those workers that care for the hospitalized in the hospitals, and therefore will have high likelihood of being infected because they work in the basic sector. And then there's the luxury sector, which we think of as entertainment, restaurant, and the like. So when we think about government shutdown policy, it's this sector that will be affected by the shutdown policies. And concretely, the government chooses what fraction M of this sector to shut down. If you're as part of that sector that's being shut down, what happens to you? You're working in that sector and you just simply cannot work. Your income falls to zero and you're reliant on social transfers for your consumption. So on one hand, if you work in the luxury sector and if you're shut out, you're less likely to contract the disease, which is good for you because you're less likely to die from it. But on the other hand, your source of income has gone and you rely on social transfers in order to make your living. So these are basically the two components of the model. And then in the context of this model, we think about two policies that interact with each other. Mitigation policy, shutdown policy, this is exactly this number M that I have mentioned so far. So one part of the policy is the optimal time path of what part of the non-essential sector to shut down, when to start, when to stop, and what is the extent of the optimal shutdown. That's one policy lever. It's an entire time path of shutdown policies, and therefore it also allows us the question that conditional on a shutdown, when should we try to open up the economy again, and to what extent should we do that? Mitigation, this policy, it reduces contagion because it reduces the number of people that work. It thereby reduces the number of people that get infected by the disease. And if the shutdown is significant enough, it reduces the risk of the hospital sector, which we model explicitly, but in a somewhat reduced form, the risk of this hospital sector being overloaded because we assume that there's a fixed capacity. by making mitigation, it might prevent the fact that the hospital sector gets overrun. But on the other hand, it reduces economic activity and therefore it reduces average consumption in the economy. So that everybody suffers from that. And it increases inequality because the more you shut down, the more people you generate that in principle could work, but currently are not permitted to work, and therefore have income of zero and rely on social transfer. The second set of policies we look at is redistribution. So redistribution will take a simple form of a transfer from those that work to those that do not work. Redistribution helps the unemployed, helps those people that got shut out by the mitigation policy, and therefore it makes mitigation more palatable because the people that now cannot work, they don't starve, but they receive unemployment benefits and therefore their consumption does not fall to zero. But if it is costly to make those transfers because you have to raise, for example, distortionary taxes, that reduces the appetite for mitigation because you know that once you mitigate a lot, you will have to transfer a lot. But if transfer comes with a dead weight loss, you might not want to do as much mitigation as otherwise because these transfers are costly. At the end, we're going to write down essentially an optimal control problem and ask if you value all these individuals in the economy, the old, the young, and the two sectors equally, how much mitigation and how much social transfers should you engineer, and what is the optimal timing of exactly those policies. So that's the precise policy question that we ask. How much and when is the mitigation? And conditional mitigation, how much social transfers between those that currently can work and those that currently cannot work. The next few slides give you the details, and here I will, I guess, necessarily have to be somewhat short. So hopefully you excuse that, but the slides are available to you. So in terms of what people like, they are potentially infinitely lived. They discount the future at rate rho. Old households are more impatient than young households, so that reflects the fact that you have less of a lifetime horizon when you're old relative to when you're young. You care about three things when you're alive. You care about how much you consume. You care about just being alive, U bar. That's the flow utility just from being alive. And then you care about your health status. If you're healthier, you have more flow utility than when you're not healthy. So this is basically a term that says, if you have to go to the emergency room, you like that you're alive, but not as much as when you're not in the emergency room. The young have exactly the same lifetime utility, but they discount the future at a lower rate. So that's a simple way of modeling that the young have higher lifetime expectancy relative to the old. So what do you like? You like to eat, you like to be alive, and you'd like not to be sick. That's the thing that you like. Now, the fact that you like to be alive and that you like not to be sick, that automatically for the young and the old endows them with a value of not being infected by corona, right? Because if you're infected by corona, you get sick, you don't like that directly, and there's a higher chance of you dying. And since you like being alive, that immediately makes both the young and the old value not being infected by corona, and therefore endows the young and the old with a preference for potential mitigation, for a potential shutdown, because the young and the old like the reduction in the probability of being infected. On the other hand, you like to eat, and in an economy where part of the economy is shut down, and therefore part of the economy is not producing, aggregate consumption in the economy is lower. Somebody has to eat up those losses in consumption, and that's the basic policy trade-off. On one hand, you mitigate part of the economy, you have lower consumption, but you kill less people, and people like to be alive, and you make less people sick, and people like not to be sick. The key thing is that there's a big difference between the young and the old in infection probabilities and in the probability of transiting into being sick and in the probability of dying. And therefore, the optimal policy combination looks very different for the young and the old because the incidence of becoming sick and becoming very severely sick and dying from the disease is very different for the young and the old. In terms of the basic economics, there's, as I said, two sectors of the economy, either the basic sector, which you will never shut down, the basic sector output, YB is given. There's a linear technology. One worker produces 1 unit of output. Who are the workers that are working in the basic sector? It's all the workers that are currently susceptible, meaning you don't have the disease, so you can work. If you're asymptomatic, you have the disease, but you have no symptoms, so you continue to work and produce. And if you're recovered, you're back to work because you don't have symptoms, so you work. So total output in the basic sector is the sum of the number of people that are healthy enough to work, meaning they either don't have the disease yet, they have had the disease and are immune, or they have the disease but don't have symptoms and therefore continue to work. In the luxury sector, exactly the same story. Output in the luxury sector is the number of people that are healthy enough to work, the susceptible ones that didn't have the disease, the people that are asymptomatic, that have the disease but have no symptoms, and the people that have been recovered. The only difference between the two sectors is the government shuts down share M of the luxury sector, which means that only 1 minus M of the workers are allowed to work, and therefore 1 minus M of the sector is operating, as part M of the sector is mitigated and can't operate. And this is a policy choice. M is a policy choice. So you immediately see larger M means lower output in the luxury sector. Total output, and therefore total consumption in the economy, is the sum of the two sectors. So we assume that there's perfect substitution across these two sectors. So you immediately see the impact of a mitigation policy on the economics. Higher M, higher mitigation means lower output, and somebody has to eat up that lower output. We assume that part of that output is spent on the provision of emergency healthcare. Theta is the number of emergency hospital beds. Eta times theta, that's the cost of maintaining those hospital beds. We assume that theta is fixed, and therefore eta times theta, that's the amount of output that you have to fork over to the hospitals to maintain the hospital beds, and therefore cannot be consumed. Okay. A little bit on the epidemiological side. So this is a little bit more technical. So let me just give you the essentials. So in this SIR model, where you have the transition between these 5 health states, the key thing really is the transition from being a susceptible person, called S, into getting the disease and becoming asymptomatic. So the entire dynamics on the household side is described by a set of differential equations that give you, this is the number of people that are susceptible by sector. So this is the number of young people in the basic sector that are susceptible. This is the change in the number of these people. There's a negative sign here. Why? Because over time, less and less people are susceptible. Why? Because more and more people get infected and move from susceptible to being infected. And this equation basically describes the share of the people that start the current period being susceptible and moving into getting the disease and getting asymptomatic. There's 4 sources of infection if you work in the basic sector. You can get infected because you work in a hospital and the sick people infected you. You can get infected because you interact at home with sick people. You can get infected because you go shopping and you interact with people that are sick and also go shopping. Or you can get infected because you work and you interact with people that are at work and are already infected. So there's 4 sources of infection if you are susceptible in the basic sector. If you are in the luxury sector, the key difference is that if you're in the luxury sector, a fraction 1 minus M of the people do not work, so the probability of getting infected is lower. And the assumption is that if you're working in the luxury sector, you don't work in the hospital, you don't get infected by sick people. If you're an old individual, you don't work, and therefore you don't get directly infected by being at work, but you get infected at home, and you get infected by shopping. And therefore, indirectly, you care about infections at work. Why? Because higher infections at work make more people being sick in the population. And since you interact with those people while shopping and while being at home, your infection probabilities go up as well. And whatever you see in terms of this being a function of M, that's being affected by the number of the share of the economy that's being mitigated by the policy. The remaining part of the health transitions are completely mechanical. Once you're asymptomatic, there's a chance that you become sick. Once you're sick, there's a chance that you have to go to emergency. And once you are in the emergency, there's a chance that you recover. And if you don't recover, you die. The one thing that I want to highlight here, the probability that you recover after being in the emergency room is reduced if the hospital system is overloaded, if there's more people in the emergency room than there's capacity. That reduces the probability that you recover from the emergency room and therefore increases the number of dead people in the economy. So that's our model of if you really have so many infections that the hospital system has more patients than it has capacity theta, then that increases the extra mortality of people in the emergency room beyond what you otherwise would have. There's a simple model of taxes and transfers. People that work get to consume CW. People that don't work get to consume CN. Where does CN come from? CN is a transfer from those people that work to those people that do not work. And we make the assumption that if you want to transfer to people that are not working, it not only costs you the dollar that you transfer to people, but it has an extra convex cost that says if you want to transfer 1 unit of dollars from working to non-working individuals, it costs you more than $1 because you have to raise distortionary taxes. And the equations are on this equation basically says that since there's an extra cost of transfer, the higher that extra cost is, the more distortionary taxation is, the more you want to refrain from giving transfers to the unemployed. That means the more inequality in consumption you have, so this is given by this equation, the more inequality you have in consumption between workers and not workers. And the more inequality means the more painful it is to be laid off because the government says you can't work. And therefore, the less palatable it is for the government to shut down part of the economy. And that's where this policy interaction comes. We stick some numbers into this economy. In terms of the broad overview, obviously the numbers that we're going to get matter in terms of the calibration. So let me just highlight 2 numbers. So here, people really like to be alive. So how much do they like to be alive? We take estimates from the value of a statistical life by the Environmental Protection Agency that values a statistical life at $8 million for a total life. So that comes down to about $515,000 or about 11.4 times per capita consumption in a given period. So people really like to live in this world. And therefore this U upper bar that just captures how much you like living is fairly high, capturing the fact that in every period where you're alive, the value of being alive is equivalent to 11.4 times average consumption. So that's a big number. And that's a big number both for the old that know that if they die, they forgo that. And also for the young, they understand that they get sick, there's a very small chance they're gonna die. But if they die, that's really painful because you really value being alive. The other important set of parameters have to do with all these health parameters. And the key thing that I want to highlight is there's very strong heterogeneity between the young and the old, which comes to the fact that conditional on contracting the disease. For the old, there's a 2.5% probability of dying at it. For the young, it's only 0.1%. What does that do to? Because conditional on getting the disease, you're much more likely to become sick. Conditional on getting sick, you're much more likely to move to an emergency state. And especially if you're in emergency care, you're much more likely to die from the disease. Once you multiply all these probabilities together, there's a big difference between the young and the old in your probability of dying from the disease, which is non-trivial at all for the old and fairly benign for the young. So these are the probability conditional on dying. We assume that mitigation follows this time path controlled by 3 parameters. This tells you what share of the economy do you initially want to shut down. This parameter essentially tells you how long is the shutdown going to last. And this parameter tells you how quickly, once you open up the economy, how quickly do you open up the economy. Okay, there's a lot of details that I want to spare you. Thought experiment is, the idea is On April 12th, you get to play policymaker to decide that before April 12th, the economy already had a partial shutdown because the governors in the US of the states had enacted partial shutdowns. Part of social distancing is also in effect. And then on April 12th, you get to make a choice. Our calibration says about 50% of the luxury sector at that point is mitigated. In April 12th, you can either decide, let's open up the economy. April 12th is Easter, just to give you some context. So this was this famous speech that initially Trump wanted to open up on Easter. So one option that the policymaker has is, let's open up the economy again. Let's drop the 50% mitigation at Easter. Compare that to a world where we keep the current mitigation till the end of June. Reality is probably it might happen a little bit earlier because states are already starting to open up. And then the third scenario, we're going to look at what is the optimal mitigation scenario, what's the optimal time path of mitigation. So what I will show you are 3 different policy scenarios. You open up the economy at Easter from a 50% shutdown of the luxury sector relative to a world where you open up the economy completely by end of June, relative to a scenario where you open up the economy optimally, meaning you pick those parameters that I've shown here, these 3 parameters optimally to maximize utilitarian social welfare. So let me show you in the last 3 or 4 minutes some results. So what I'm showing you here is 2 scenarios. Scenario blue is scenario where you open up the economy completely at Easter. Scenario red, that's the scenario where you keep the mitigation, 50% of the luxury sector shut down, and you keep that until the end of June. What I've shown you here is the number of daily deaths under those 2 scenarios. So the current scenario, which we think to be the benchmark, is a scenario where 50% of the luxury sector is shut down on April 12th and remains shut until June 29th. And what you see is the number of daily deaths hovers around the 2,000 that we currently observe, but is slowly falling towards the end of June. Then if you open up, infections build up again towards the fall, and you get an increase in the number of daily deaths towards 4,000. So if you were to ask us what is the most likely scenario under current policy, we would say that's the red line. Contrast that to a blue line where you have opened up on Easter, the number of daily deaths is multiplied by a factor of 4, 10,000 daily deaths spiking around mid-May and then rapidly falling because more and more people are infected, more and more people have died, and therefore more and more people are immune. The other thing that I want to highlight here, this is the total number of daily deaths. Look at the last panel. This is the number of daily deaths among the old. Most of the death in society coming from the death of the old people because they have higher incidence of dying. And you can see, according to these 2 scenarios, the total cumulative number of deaths as we push this economy through the economy. If you mitigate at Easter, you have many more deaths initially. But if you look at, as the pandemic evolves, eventually what this higher mitigation does for you, it's true, you have fewer people that eventually have died, but to a large extent, it just postponed the number of deaths as opposed to preventing the number of deaths over time. And that shows it to you. If you look at the percentage of the people that die among the elderly, it's true that if you don't do mitigation, the elderly die much more quickly. But at the end of the day, the number of total deaths among the elderly is not all that much different between mitigation and no mitigation. So the story is you postpone mitigation, or you postpone the number of deaths, you prevent some, but not all that much. Okay. How about the optimal policy? So now you asked, what should the optimal policy look like? There's 3 groups in society: the old, the young working in the luxury, and the young working in the basic sector. So what this shows is the optimal policy path of mitigation if you were to ask the old people. If you were to ask the old people, they say on April 12th, instead of 50% mitigation of the basic sector, reduce that to 30%, but keep it for a long time, well into the fall. If you ask the young luxury workers, They, in contrast, want lower mitigation, and they want it to end more quickly. And why that is obvious, right? I mean, the old guys, they don't want to die. They don't want to be infected. Therefore, they want long mitigation. It's true that they understand their consumption is lower because they rely on transfers from the workers, but their life is really valuable to them. If you ask the luxury workers, they also understand they might die from the disease. They get infected, but on the other hand, they are not as likely to be infected and dying. On the other hand, they're infected by the lower consumption despite having social transfers, and therefore their optimal policy is lower mitigation and much rapidly closing down that mitigation towards opening up the economy. If you do utilitarian, the weighted sum of these policies, weighted by the number of the share of the population, you get the optimal policy rule, which looks like that. Lower mitigation than what we currently have, but more long-lasting. And the welfare implications are pretty stark. So from the utilitarian policies, you see that the old guys very strongly benefit from this policy relative to opening up the economy on April the 12th. So the main beneficiaries of the mitigation policies are the young luxury workers and the young basic workers. They do benefit because they do care about not getting sick and not dying, but it's not that likely for them. But the economic costs are mainly borne by them. So all said and done, it's true that they rather have this policy rather than opening up the economy completely, because opening up the economy completely leads to this massive amount of death and complete hospital overload. But the big welfare gains from the mitigation policies are taken by the elderly. Let me show you one last picture because that's fairly drastic, and then let me conclude. We have all kinds of policy exercises in the paper, but the one policy exercise that really affects optimal policy is, I would call it the rosy glasses of hope. Suppose somebody tells you a vaccine is coming in October, which is the most optimistic view of a timeline of when a vaccine might be available. Suppose somebody tells you on October 12th, there's a vaccine, we can vaccinate everybody, and that stops all new infections cold. How does that change the optimal mitigation strategy before October 12th? Very, very drastically. This was what I've just shown you. You go from 50% mitigation on April 12th, you open up part of the economy, but you keep it into the fall. If you ask now the old guys, suppose there is a vaccine on October 12th, what should the optimal policy be? They essentially tell you up until October 12th, shut down all the luxury sectors, shut down all the restaurants up until this point. And why is that? Because under this policy, you don't avoid death, you mainly postpone them. With a vaccine on the horizon, you know you just have to get to mid-October. At that point, there's a vaccine, and then you can kill the number of dead people. No, not the number of dead people. You can kill the incidence of deaths from the virus, and that's what you should do. So a vaccine on the horizon very strongly affects your optimal policy, because it basically says is that with mitigation, we will postpone deaths. And if there's a vaccine on the horizon, we should postpone the death up until the time when the vaccine comes. And for sure, the old guys, that's what they really want to do. For the young guys, they say, well, we understand that, but the economic costs are just too large. But the upshot is, with a vaccine on the horizon, or with a good chance of a vaccine, you have much more drastic mitigation policies, because you just want to postpone the number of deaths up until you can vaccinate everybody and deal with the number of infected people in that way. We have all kinds of things. Antibody tests, suppose you can tell who is infected or not. That's surprisingly ineffective, and I can in the Q&A tell you why that would be. So vaccines, very powerful. Antibody tests doesn't matter all that much. So the unconstrained optimal policy looks very much like the parametric policy with 3 parameters. So fully optimal control doesn't do much relative to optimal policy in this 3-parameter family. So let me just conclude. So the current baseline simulation suggests that you want to have mitigation policies that are perhaps a little bit lower than the ones that were in place up until April 12th. but you want to keep them well into the fall. The welfare gains are very uneven. The old are very strongly positively affected by economic mitigation. It's not so great for the young because they're the main bearers of the economic costs. I haven't talked too much about that. The cost of redistribution matters. If it was costly to reshuffle $1 from the employed to the unemployed, you would do much more mitigation. And one thing, and that is just a statement of honesty, do parameter values matters? You bet they do. Especially the value of life matters quite a bit for the optimal mitigation policy. And how lethal the policy is, especially for the old, that matters quite a bit too. If we have massively overstated just how deadly the disease is, conditional on the old going to emergency, obviously that would massively change mitigation policy as well. So, but I think of this as actually a good aspect of a good quantitative model. You do want to make a model where you know what matters in terms of your input, and then you can have a debate about what the optimal inputs are. And the cool thing about this research is this is going to be a debate not only among economists, but you have to talk to your epidemiology friends, because a big part of these parameters that the numbers really depend upon come from that literature.
Well, thank you very much, Dirk, for this excellent presentation. Very clear, very important. Not all very encouraging, but some of it, yes. So thanks a lot. That's great. We still have 15 minutes. Let's go straight to some of the questions. Unless, John, do you want to ask a question right now? Okay. You have to. Okay, so let me go to this first question by Robert King, which was asked early on. So you may have touched on it, but let me read it. Will you allow for age-specific shutdown, that is, have the old people stay home and others not? So a more stronger protection of the old.
Yes, that's experiment that we just did. And so the thought experiment we did is the old don't get directly infected while being at work. Right, so the old, by assumption, are completely shielded from direct infections at work because they don't work. But the old still care about who gets infected at work because they interact with them while consuming and while interacting at home. And the key infection in terms of magnitude is it's really risky for the old to go shopping because that's where they interact with these young people that are infected. So the thought experiment we did is suppose you can completely kill the infections of the old people while shopping by either quarantining them or giving them special shopping hours, like all over the US. The old can shop from 7 to 9 in the morning. Nobody else is allowed in the store. Suppose you stop that, and therefore you stop infections very massively. What you get is you basically avoid more than half of the death of the elderly, and the mitigation does not have to be nearly as severe. Why? Because you have a much more targeted intervention, which says, let's not infect the old guys while shopping. Most of the infection of the old guys, according to our model, occur not at home, but rather while shopping. Once you stop that, that is a very effective policy. Of course, you know, from a Minnesota side perspective, I'm a little bit nervous about that because that really changes the technology in the economy. It changes the infection technology. It insulates people from infecting themselves while shopping. If you could do that costlessly, this would be a fantastic policy. And our results suggest this would be very, very effective. And if you could do it, you should absolutely do it. You know, letting the old people not work, that would do nothing in our model directly because they already can't work by assumption. So that wouldn't do anything. There's a very nice paper by Chris Phelan, Chari, and Rishabh that basically look at a more detailed such policy where the old guys can also work, and they have it as, this is the difference between the hammer. The hammer means you just mitigate the economy, and the scalpel is that you're really finely targeting your shutdown policy towards the old. Certainly our consumption experiment suggests that would be very, very effective. There's a paper by Ivan Werning, I should add, that also has this type of a flavor. If you can target these policies more finely to those that have the most to gain from it, which the elderly, that's something you always should do.
Well, thank you. I mean, just I need to throw in just from what I experience at the moment in Germany. I mean, we have elderly people, we've opened up the restaurants. So you see high-risk people sitting in restaurants. At the same time, we have children at home and their parents because the schools are still open minimally. So suboptimal, I guess, from your perspective. But just as a comment. But let me read the next question here. Ricardo Rovelli from FT of May 21, according to a Fed survey conducted in early April, 39% of people in households earning less than $40,000 a year who had a job in February lost it in the early stages of this outbreak. That figure compares with 19% for households with incomes ranging between 40,000 and 100,000, and just 13% for households earning more than 100,000. So it sounds more rich versus poor than young versus old, or isn't it? So how does that fit into your framework?
Yeah, so I mean, it is important. So within the young, we have this very stark heterogeneity between people working in one sector relative to the other. So we have this heterogeneity within the young, some that are very strongly affected, others are not. Now, it's true that conditional on working, there's no heterogeneity in income between these two people. So, you know, our heterogeneity among the working people is those that work in the restaurants, as opposed to those that work in essential sectors that don't get mitigated. But on the other hand, we have very strong transfers. So from the perspective of our model, we would deal with this heterogeneity by just giving very generous unemployment insurance benefits. And this policy combination is important because if you could not do that, suppose you could not give these very generous transfers, then of course the policymakers will understand that if you mitigate these guys, if you send them home, and if you can't give them transfers, then these guys would starve. This would be very bad policy, and then you would not mitigate as strongly. So if one would model more explicitly rich versus poor, and if for some reason, which would be outside our model, you could not give effective transfers to the poor that get unemployed, what you then would do, you would reduce the amount of economic shutdown, because then you would have this group of the population that would starve. You, for some reason, can't give them effective transfers. The policymaker understands that, and therefore would reduce the amount of mitigation that would be optimal. In a way, it would look fairly similar. It would look fairly similar to the picture. Let me see. To the picture. If you were to ask young luxury workers, they really don't like a lot of shutdown, and they like it to come down very quickly. If you ask the poor people, if they don't get significant transfers, they would have optimal mitigation policy that would look fairly similar to those. Because on one hand, they also value not dying from the disease, but on the other hand, the economic consequences are so severe that they would say, shut down only a small amount, and the moment the infections are sort of a little bit controlled, open up the economy immediately. But I'm totally sympathetic to the heterogeneity also by income. In our economy, if that were the case, optimal social transfers would effectively take care of that. If that couldn't happen, you know, then you would have less mitigation policies or more targeted policies.
So here is a question by Brigitte Begado, added to Robert King's question: would the population age distribution of the different income brackets or in each of the sectors of basic versus luxury sectors be a greater effect given the age discrimination of the disease impact?
Yeah, so I mean, from the perspective of the model, the answer would be no, because within, so we have young and old, the old don't work at all, the young all work, and there's no heterogeneity within the minus 65-year-olds. And the numbers that I showed you for New York might suggest that maybe we should introduce a third age group between the age of 50 and 65, because this is an age group that are more, that are still working, predominantly still working, but there the risk of contracting the disease and dying from it is non-trivial. So if you have a group of people that are both still working, but have elevated probabilities of becoming severely sick, meaning sort of a hybrid between our young and our old, then what you would like to do is to have an age-dependent policy that says, if you can't tell directly who's sick or not, and what sectors are more infected than others, again, this is a paper that I have with Harald Ulich, suppose you can't, then you would basically do tagging. So the optimal taxation literature has told us that, you know, if you can tag optimal policy by observable characteristics, you often want to do that. If you can tag this optimal shutdown policy by age, and if there's 50 to 65-year-olds that work and that are more likely to be affected, then you should tell not everybody to stay home in the basic sector, but basically select only those guys that are in the age between 50 and 65 and say, look, you guys are more severely affected by the risk. You guys stay home and we deal with your income losses by generous social transfer. So if you could do it, that's certainly something you should be doing. And the paper by Ivan Werning and Daron Acemoglu and co-authors have a flavor of analyzing exactly that.
So there's a question, do you consider making the probability of dying from COVID-19 depending on the number of people infected because healthcare resources are limited and a scarce resource?
No,
it seems you have an element of that in there.
Yes. So I glossed over this quickly, but this is what, let me see. This is what this equation basically says. So in a nutshell, this is the change in the number of people that are recovered. And the change in the number of people that are recovered is driven here, the people that are in the emergency room. And there's a probability that they recover from that case. And then there's this parameter phi, which is either 0, but it is becoming positive if the number of people in the emergency room is larger than capacity theta, then phi becomes positive. That reduces the recovery rate of people from emergency into recovery, which means that once you're above capacity, then the probability of recovering from the emergency room falls. And if you don't recover from the emergency room in our model, you die. And in fact, the number of dead people in the two scenarios are very strongly driven by exactly activating this mechanism. If you don't do anything, you have 12,000 people that are dying per day. The emergency room capacity is about 2,500 effective death per person. So the excess number of deaths, because you don't mitigate, is coming very strongly from the fact that if you don't do anything, you completely overload the hospitals. That elevates death probabilities because you have to go to triage, and that means you have more death than you otherwise would have. So this is something that's there. You might think this is too crude, but it's certainly there, and it's a very important aspect of why you have so many more people dying if you don't mitigate relative to mitigation.
Thank you. We're getting close to 6 o'clock here, but we still have a bit of time. And if there are questions, we can still go a little bit over. But I know, John, you have to leave right on time. So in 2 minutes, do you want to throw in, or do you have another question you want to throw in now?
The only thing is that I think the first of Dirk's conclusions was that we need to keep the mitigation in longer, but we should begin to relax. I just wondered, that's relative to what?
That's relative. So we play policymakers on April 12th. We asked people, what is the optimal path that we should choose? That is relative to our benchmark scenario where you keep 50% mitigated up until June 30th. So what we would conclude is that the initial mitigation was perhaps slightly too large. But if you open up on June 30th, that would be too quick. In fact, if you open up now, that would distinctly be too quick. And the reason would be we were going to get a second wave. And by the way, that second wave, it will take a while for that second wave to materialize. So the fact that you open up and you said, gee, but nobody is dying more, that's a wrong conclusion. The deaths are going to come, but they're going to come with a delay of about a month or so. So the fact that we have opened up and nothing much happened, that is not yet sign that opening up is benign. So it's relative to a path that says 50% until June 30th.
Okay, thank you. Thank you very much.
There's one point. There's one point I wanted to quickly throw in, and you had mentioned that in passing. That's testing. So, I mean, one has the hope, or I have the hope, that if we were able to test everyone all the time, say everyone gets up in the morning and does this quick test, that it would be possible to control this very effectively. But you hinted that that's not the case in your model.
Oh, no, I have to clarify this. So there's two types of tests. It's those that we go in and you test the susceptible and the people that don't have symptoms. And if you could do that at very high scale and then tell the asymptomatic, those guys that are infected but don't have symptoms, you guys, you tested positive, you stay home. That would be very effective. What I said is that suppose you test those guys and the ones that are tested to be immune, so the antiviral tests, and you give those guys a passport that says, look, you have tested, you are immune, you can go to work. That part of the testing, that is not very useful, because early on, when the disease starts to spread, there's basically nobody of these people. And once there's a lot of people that are recovered, and where you could test and say, you have recovered and you can go back to work, that's at a stage, by the time there's a lot of people of that time, at that point, the epidemic is controlled very effectively anyway, so that wouldn't do any good. So testing, if you want to test in order to give somebody a passport saying you had it, you can go back to work because you're immune. From our conclusion, that does very little. Testing those people that are they're susceptible or asymptomatic to avoid them going to work in the first place, that likely would be very effective, but you would need massive amounts of test capacity to do so.
Thank you.
There's these two types of tests: those that basically testify that you're immune and can go back to work, and then those that are the tests that are detecting whether you are asymptomatic but you have the disease. Two very different types of tests.
Thank you. There are some questions. I think we will not be able to get to all of them, but we can still take 2 or 3 minutes to address some of them. One question is about, or let me mention this comment first. Robert King had a comment which he had to leave by now, but he says, in terms of linking to DSGE modeling, it is worthwhile pointing out that some of the epidemiology work is using Bayesian methods to estimate models. Their confidence sets are wide. Interestingly, the papers are much less clear than the typical Bayesian DSGE model. Do you want to comment on the testing, on the estimation, and what you've learned about that?
Well, I mean, I think the reason, so I totally agree that the confidence bands with respect to the AP type parameters are large. I totally acknowledge that. And it is the case that I think maybe once you have a lot of experience with DSG models, forecasting economic activity in normal times is just prone to way less risks than a rapidly unfolding epidemic where basically daily the number of observations change. I mean, the one thing that is true is, these models, if you have something that unfolds very rapidly, initially as exponential growth, and if you have a parameter that governs the exponential growth rates, small changes in that parameter has massive consequences, because that's the nature of exponential growth. The difference between a growth rate of 1% and 2% is just, even over short periods of time, it's just massive. So I think that would be, so I fully agree with this, but I don't think that that's necessarily a knock on the epidemiology folks. It's just that they deal with very rapidly evolving phenomena where a small change in the growth rate leads to a large change in health outcomes.
Then there's a question, did you apply the model to different countries, or a suggestion to apply it to different countries where you have different age distributions, African countries, or different approaches, such as in Sweden? The person says, my gut feeling would be the model could nicely explain the course of the disease in different environments. Yeah,
so the short answer is we haven't. And I think there's, in principle, this is a perfectly mobile environment. You could apply it to everyone, but of course the crux is in the parameter values. And if I were to guess, so one thing that this model sort of relies on is to get April 12th in terms of the state of the epidemic right. And in order to get that right, requires not only estimates in terms of how much shutdown we did in the economy, but also how much social distancing there is. So you cannot take the numbers that we have here and transport them to a place like Sweden, because social distancing is important in our environment. How? Because it changes parameters prior to April 12th. And we know this is very important. And if you have much more social distancing, because the government says, look, we don't shut down the economy, but we really coordinate expectations on very strong social distancing, that is very powerful in our model. So we could not take the results one for one, but conditional on different parameter estimates, this is certainly an environment that you could use for other countries as well. And the key two parameters are how big is shutdown. Clearly that matters early in the epidemic, but also how effective is the government's ability to convince people to do social distancing, and how strongly does that affect the contact rates early in the disease. From our perspective, early disease means somewhere between mid-March and mid-April.
Okay, one other question here. In the trade-off between wealth dimension and health dimension, which dimension characterizes the optimal policy of shutdown and redistribution in your model? Maybe means also which has more influence, which element. Can you say something to that, or is that?
So the one thing I can say is that, I mean, health is mainly driven by this value of life, which is quite substantial. So one thing you can do is to say, you know, the Environmental Protection Agency's estimate of the value of life is crazy. Now, nobody's worth $10 million, and maybe there's heterogeneity in that as well. Suppose you cut that to 2 million, then suppose you cut it to 500,000. Then we know optimum mitigation is 0. Then you just let it drip. Now, if you don't really care that much about people dying from the disease, the main aspect for why the policymakers does mitigation is to save the old people primarily. I mean, everybody else too, but the old people from getting sick and dying. If you don't care that much about that relative to being alive, you just let it rip and that's it. So I mean, you know, here's sort of a knock on cross-country comparison. If the value of life is only $500,000, whatever that's worth in kroners, yeah, then you let it rip. Absolutely. They're very important how much the value of life is to the policymakers, meaning how much is it worth to you?
Well, I think this was great.